Hello, my name is Bella Blankenship, and I'm a PharmD student at Drake University. Today, I will be briefly discussing sulfonamide drug hypersensitivities. Here's an outline of what I'll go over today, starting with some background information, then moving on to presentation of the reactions and how to manage them, and then some implications for the information. To begin, sulfonamides are a class of drugs that contain a sulfonamide moiety, as shown on the right of the diagram. Sulfonamides include sulfamethoxazole, as well as some less common ones that we think of, including furosemide, celecoxib, thiazide diuretics, sulfonylureas, and sulfasalazine. Most reactions to these drugs are caused by the arylamine group, which is only present on sulfonamide antibiotics like sulfamethoxazole. Reactions to those antibiotics occur in about 2 to 4% of healthy patients, while sensitivity rates can be as high as 65% in patients with AIDS. Reactions to these drugs can vary quite widely. Patients can experience urticaria characterized by itchy, swollen areas of the skin that are raised. It can also present as a morbilliform rash, which is the most common presentation that we see. Angioedema can also occur with varying severity and is characterized by swelling under the skin around the eyes or lips. More life-threatening reactions include anaphylaxis, as well as Stevens-Johnson syndrome and toxic epidermal necrolysis. SJS is characterized by discolored skin lesions involving less than 10% of the body surface area, while TEN involves over 30% of the body surface area and is characterized by blistering and peeling of the external skin layer. For treatment of urticaria or rash, the offending drug should be discontinued. Angioedema is managed with epinephrine and an antihistamine like diphenhydramine with airway support if necessary. Anaphylaxis is considered a medical emergency, and so the primary focus should be maintaining the airway and proper breathing, and then immediately administering epinephrine. Fluid resuscitation and diphenhydramine are also components of anaphylaxis treatment. SJS and TEN are treated in burn units in which the skin barrier is restored through a variety of methods. A past history of anaphylaxis, SJS, or TEN is an absolute contraindication for future use of that offending drug. But if a patient experienced urticaria, rash, or mild angioedema, clinical decision-making should then be utilized to determine if the treatment is appropriate to use again or if perhaps an alternative would be beneficial. There is a low chance of cross-reactivity between sulfonamide compounds, so someone with an allergy to sulfamethoxazole may not necessarily have any reactions or issues to other sulfonamide drugs. Allergists also agree that most patients with a sulfonamide antibiotic allergy can tolerate those non-antibiotic sulfonamides, but alternative treatment options are available. These aren't necessarily therapeutic equivalents, but alternative therapies could be used if a clinician wanted to take a more conservative approach in treatment for a patient with a documented sulfonamide allergy. So ethacrynic acid, spironolactone, or triamterene could replace furosemide or thiazide diuretic in therapy. Naproxen or ibuprofen could be used in place of celecoxib. And then there are multiple options to replace sulfonylureas, including DPP-4 inhibitors, thiazolidine diones, or SGLT2 inhibitors. In some situations, desensitization might be warranted. And sulfamethoxazole with trimethoprim is the drug of choice for PCP prophylaxis, which is particularly relevant for patients with HIV or AIDS, those with a solid organ transplant, or those using corticosteroids long term, as all those patients would be immunosuppressed. Risk versus benefit should be assessed in this case, and a history of anaphylaxis, SJS, or TEN would be an absolute contraindication for the procedure, and it should only be performed in a hospital setting. The dose is then gradually escalated, beginning with 1% of the therapeutic dose and utilizing continuous monitoring for signs of a reaction. So there are a few implications for this information I've presented. EMRs often alert prescribers that a patient with a documented sulfa antibiotic allergy cannot take another sulfonamide drug, but in most cases, the allergists have agreed that the patient will not experience cross-reactivity. We can also use this information to educate patients on the difference between hypersensitivity reactions versus just expected side effects of certain drugs. And it's also important to engage in constructive conversations with prescribers about potential alternatives to therapy. Here are my references, and thank you for listening to this presentation.